Hey, future respiratory therapist. Hey, I just want to talk to you here for a second. I don't have my whiteboard with me today. This is not anything that's a lesson that's going to help you on a test or an exam. I just want to talk to you for a second because there's a trend happening over the past several years that is very bothersome to me. And that is the fact that several respiratory therapy departments are deciding that because of the beneficial aspect of it in terms of profits, that incentive spirometry is something that is no longer valuable to the respiratory care department and something that nursing is taking over. And on one level, I get that thought process, okay? If it doesn't make dollars, it doesn't make sense. I get that. But on another level, I'm going to make an argument for you. As respiratory therapist and future respiratory therapist, you got to understand that incentive spirometry is one of the few modalities that we actually do that will give us objective data to document as an indication to either the degradation or the progression in a patient's hospital stay. And I don't understand why, because of cost or because of dollars, we've decided that incentive spirometry is something that nursing could do. You know, I kind of think about it like this, and that is if you call a plumber because your toilet is stopped up, what if that plumber told you, you know what, I appreciate you calling me, but that's no longer something that I do. I'm going to refer you to this carpenter now. And you could probably call the carpenter and they could probably get the job done. They would probably charge you whatever they charge you, and they could probably unclog your toilet. I actually believe that most homeowners could probably unclog their toilet if they really wanted to. Most people don't want to bother with it. And that's what leads us to this point now to where it's like, okay, if it doesn't really make us a lot of money from an RT department standpoint, then let's just push this off on nursing. And if you're a nurse watching this, or you know a nurse, I want to tell you this. I love you. I love the vast care that nurses provide. 100%. This is not a knock on nursing. If it was up to me, I would take as many things as possible off of nursing's plate. But what I find myself in is this situation to where I see a lot of departments giving more to nursing, putting more on their plate. And I feel like that's a disservice to one, nursing, and to two, it minimalizes the true impact and true effect that an incentive spirometry can tell you about your patient. And so I want you to think about this. Some of you may say, Joe, why are you telling us this? We're students. We don't have the ability to change this. We don't even ever really even have input in this. So why would you tell a student this? Well, here's my answer. I'm telling you because you're the new mindset that's going into the workforce. The old mindset that's there, they don't see it this way. They see IS therapy as something that is trivial, something that is disposable. They don't see it for truly what it is. If you have a patient, especially in the post-surgical units, if you have a patient that begins to go downhill due to atelectasis, and IS is one of your most beneficial tools to indicate that. And if you guys will remember this video and remember these words, then my hope is that you will go out and you will say, whoa, wait a second. We've given IS therapy to nursing. They may or may not be doing it correctly. Why don't we take this back? Why don't we take IS therapy back into our control, and why don't we use this tool that will give us objective measurements as to the progression or the degradation of our patients to ultimately reduce the escalation of care? A patient that is giving you pathetic numbers on our IS, and then they become hypoxemic, you probably won't know about it until it becomes a rapid response issue. Where if you were there the 24, 48, maybe 72 hours prior to, you maybe could have been the identifying factor that this patient is getting worse, not better. And that's what I want you to take away from this, is that people always talk about respiratory therapy needing to change, and we need to become value driven. Add value. Well, add value means nothing to anybody these days because people have been saying that for years. So don't be value driven. Be more along the lines of impact driven. Have ideas, have thoughts that impact change within the respiratory therapy community or your respiratory therapy program or your department. That's really what I'm trying to say is come up with ideas that can drive the respiratory care department to be a department that becomes indispensable, not because it adds value, which nobody even really knows what that means, but one that impacts change and impacts change within the patient care that leads to positive outcomes. And when I say positive outcomes, I'm talking about the reduction in the escalation of care. Okay? Does that make sense? Now, some of you may be thinking to yourself right now, like, well, why would a respiratory therapy department even give away a respiratory therapy procedure? And my answer to that question is simply this: because it doesn't make dollars. So give away the dollars so you can get more dollars brought in. And when I say dollars brought in, I'm really talking about free up somebody from having to go do 20 IS therapies. And if you free that up, then that therapist is now available to go do 20 small volume nebulizers with albuterol, or maybe Duanel. Who even knows what you're nebulizing, okay? But it's going to make more opportunity for you to go give those treatments. Now I want to talk about that for just a second. Does this make sense to students coming into this field? And if you're already graduating and you're watching this, because anybody can watch it, then ask yourself, does this make sense? How many of your albuterol small volume nebulizers are actually indicated? How many treatments do you see a day that have clear breath sounds, no shortness of breath, no wheezing, no nothing, that you go and see every 4, maybe every 6 hours to give a small volume nebulizer with albuterol in it? So what we're doing is we're giving away therapy that we can actually impact change with and reduce the escalation of care with, to do therapy that in most cases is not even indicated. And more importantly, there's probably therapists out there that are doing 3, 4, 5, 6, 7, 8 treatments at a time, which is called treatment stacking or congruent therapy, which is completely a waste of time. If you're stacking, then start packing. We don't need you. We don't need respiratory therapists that do 8 treatments at a time. That's not quality care. That's quantity care. And that is ridiculous and completely outdated. The truth is, you can only do 1 IS at a time. It will give you objective data that will indicate that you can track and see if your patient gets better or worse. And that's the message that I want to send to you now. As future respiratory therapists, go into your workplace with a mindset of making positive changes, something that will impact caregiving, something that won't just be, oh, I can go give 80 treatments in a shift. You're just like everybody else. And I tell you students this because I don't want you to be like everybody else. You have a mind, you have a body. Go create change in the benefit of the people we take care of. Go be great.